All right, everyone. Thank you for joining for this week's update call for clinicians. As I had said previously, Shelley Fiskus is not here today. So myself, I'm Dr. Amelia Keaton. I am the Interim Director of the Healthcare Associated Infections Program at the Tennessee Department of Health. And Dr. Paul Peterson, who's the Director of our Emergency Preparedness Program, are going to try to struggle through this call today and hope that we do justice to the calls that Shelley has set up. So just a quick reminder, next week there won't be a call. We'll resume the weekly provider update calls on July 10th. In the meantime, feel free to regularly check back with the Tennessee Department of Health COVID-19 website and also CDC's updates for coronavirus. And you can see the links there on your screen. So we are now 163 days into the Tennessee Department of Health Incident Command Structure Response. We have now made it 113 days since our first case was diagnosed in Tennessee. We still have our clinician call line open, and that's available 24/7, although we ask for routine questions that can wait to the next day. Please do if it's after hours. We do have physicians on call, but we also need them to be able to sleep too, if at all possible. In terms globally, I'm sure that folks on this call are keeping up with the news worldwide. So from last week to this week, we saw a pretty sizable increase in the number of confirmed cases of COVID-19. That has been reflected also in the United States, where we are now up to 2.4 million cases, which is up about 300,000 cases from last week. We're starting to see more and more states with increasing case counts. As I'm sure a lot of you are aware, some of the ones that have been mentioned are Texas, Florida, and Arizona. Here in Tennessee, we're also seeing increases in cases, particularly in some of our larger metro areas. So as of yesterday, we had 686 cases, new cases diagnosed. We will have our, 799 cases diagnosed since yesterday. That number has steadily increased throughout the week, as I'm sure a lot of you are aware. We're still seeing high numbers of cases in the large metro areas in Tennessee, including Nashville and Memphis, although other areas are starting to have higher case counts as well. One of the new features on our website that I know folks may have seen is our long-term care facility visitation. So our unified command structure reopened visitation to counties meeting a specific recent case rate by county threshold. So those counties that have fewer than 10 new cases per 100,000 residents over the past 14 days can consider visitation in long-term care facilities. That is not by any means a requirement, and facilities can continue to make their own decisions regarding that visitation practice. But coincident with a lot of things reopening across the state, we've seen case rates increase from last week to this week, as you can see on the areas on the map. So the orange counties are the ones that are above that case threshold and should not consider visitation of long-term care facilities, and those that are in blue are still considered to be below the threshold. So just to kind of break things down by county so that folks know how to interpret this metric. So what we're looking at is that 14-day average case rate, which you can see at the bottom of the screen. The graph that you see above that shows the average case rate by specific day. Since there can be quite a fluctuation in cases from day to day, we encourage people to use that average rate, which should not change as rapidly as the day-to-day rate above. In terms of a few hot topics, so one of the papers that was released this week regarded hospitalization and mortality among Black patients and white patients with COVID-19. And this was a study that was out of Louisiana, where they performed a retrospective cohort study of 3,481 COVID-19 positive patients in one of their large healthcare systems. And what they found, disturbingly, was that even though their typical population, our patient population is composed of 30% Black patients, of their hospitalized patients with COVID-19, almost 77% of those patients were Black. 70.5% of the deaths that they saw in this hospital system were Black as well. They did find that Black patients were more likely to be hospitalized, but not more likely to die from their illness than non-Hispanic white patients. This paper doesn't get at the reason for this disparity. A few of the hypotheses that the authors mentioned are that Black patients may be more likely to serve in occupations where they have more community exposure, so things like service industry jobs. They also found that of the Black patients that they reviewed for this study, that they had higher levels of inflammatory markers, elevated creatinine, and elevated AST levels, which suggests that perhaps these Black patients waited longer to seek care than others, but again, cannot confirm that obviously from the study that was done. And then finally, we know that there is a higher instance of certain comorbidities in Black patients, so some of those things would include obesity, type 2 diabetes, and heart disease, which may predispose Black patients to more severe illness, unfortunately. So I think this paper really emphasizes our need to continue to perform outreach to all populations, but in particular to Black patients and Hispanic patients, because this is not the first paper to report disparities, and I think it's something that we, as public health officials and also as providers, should really keep a focus on in the coming, as we continue to evolve in this pandemic. A few other studies that came out this week. So the NIH halted their clinical trial of hydroxychloroquine. So this is the ORCID study that they had been conducting. So you can kind of see in the headline there the summary of why they halted it. So the investigators did not find an added benefit of this medication. They did not find that it did harm overall in their analysis, but they did not find that it was resulting in significant improvement or alterations in the clinical course of patients, so decided to stop that trial. And then another paper I think that is concerning and that a lot of folks might have heard about is the findings in pregnant women who are infected with COVID-19. So some pretty startling statistics are that pregnant women are 5.4 times more likely to be hospitalized than their non-pregnant counterparts. They're 1.5 times more likely to be admitted to the ICU and 1.7 times more likely to be ventilated once admitted to the ICU. Although there was no difference in mortality rate in this particular study, I think the fact that they are more likely to experience severe illness is another just reason to highlight the need to continue to remain diligent in some of just the basic practices of social distancing, trying to avoid crowded places if at all possible. I know things are opening up and folks have been inside for quite some time related to COVID-19, but particularly if you're in one of these groups that is considered higher risk, please wear your mask when you go out. Pay attention to things like hand hygiene and environmental cleaning, and just avoid places where it's difficult to socially distance yourself. And with that, I will turn things over to Dr. Paul Peterson, who will give probably the more interesting part of this call, which is how to set up an alternate care site in Tennessee.
Okay, great. Thank you, Dr. Keaton. And thank you all for joining. Really appreciate the opportunity to kind of share what I've been doing for the last 3 months. It seems like I've been in a black hole somewhere. Typically, I'm the director of the Emergency Preparedness Program here at the Department of Health. But over the last few months, I have been kind of one of the leads over kind of implementing our strategy to develop alternate care sites in Tennessee. And have had some awesome partnerships with folks all across the state, from healthcare providers to the U.S. Army Corps of Engineers, to staff at our Tennessee Emergency Management Agency and the Department of Military, and a lot of public and private sector partners. Today I'm going to kind of just go over these quick objectives and set the ground for what we've been doing. I'm going to enumerate some of the different clinical aspects and the scope and patient populations that we are willing to be able to see at one of these alternate care sites, and importantly, the populations that we are not. Review some of the site design and construction efforts that went on. Look at, we build it, but then we also need staff. So how are we going to manage staffing a resource like this? Describing the wraparound services and the immense amount of contracts and infrastructure that you have to have in place to be able to support a facility like this. analyze some of the logistics and the procurement and all the different supplies and equipment that you need to be successful. And then finally, just kind of briefly discuss some of the exercise things that we've done to help test the plans that we're putting in place. So, of course, historically, this is what an alternate care site looked like. So, you know, back in the early 1900s, we've got various different aspects. We've got some alternate care sites in a building of opportunity, it looks like, some out in open air spaces for good airflow, some with good distancing between individuals. Other things I take note of in this picture is personal protective equipment on the staff. Some looks like it's homemade. And also looking at, you know, there's likely limited staffing at these sites and limited medical care. All of those things I just talked about really are what we're seeing again today. So I think the look and feel of what we're implementing is a little higher and more advanced strategy, but some of the lessons learned from earlier generations can still be put into play today. And as we try to build infrastructure and do something that we probably never thought we would do. So I am not a hospital builder by trade, so this has been an interesting experience, kind of learning this process and kind of meeting the needs. So one of the interesting things early on, I'm sure you guys are all aware of this IHME model from University of Washington that basically the White House and everyone was using for modeling to kind of demonstrate a shortfall in hospital capacity across the country. And so early on, this really got my eyes wide open and made all of us really concerned, because in Tennessee, you know, in late March, we were learning that we were going to have over a 7,000 floor bed shortfall, 600 ICU beds, and have a huge deficit in ventilators. And so that really kind of kicked off this whole planning process. And with that, basically kind of how it started was the U.S. Army Corps of Engineers. We started reaching out to governors and to departments of military in each state and basically talked about, you know, the U.S. Army Corps of Engineers has capacity to help build alternate care sites. And seeing these shortfalls, they were basically starting that process of if there is a need, here's a resource. And so that's kind of how the conversation started. So in Tennessee, what that basically created was a need to do some community engagement, to do some identification of resources. So that's exactly what we did. We started looking at, say, buildings of opportunity, reaching out to partners across the state, seeing who had facilities that would kind of meet some of the needs that we had. And so that process was pretty incredible, just the number of interactions. I think the state of Tennessee wins the award for the most U.S. Army Corps of Engineer evaluations of facilities. I think we did over 45 different site reviews trying to find the best location. And one of the things that we did run into early on, we did select a site here at the Music City Center, and that ended up having to be kind of put on hold because of some of the information, because as soon as we started the planning, then the modeling changed. And so all these bed shortfalls and ventilator shortfalls pretty much evaporated. So thus we had to really look at, okay, what does the strategy look like for us? We're seeing shortfalls still in other areas of the country, and how do we shore that up? So we started looking more, okay, what is the long game for this? And so we're one of very few states that actually has facilities where we actually have long-term leases to help support a response for up to 18 months. And most other locations that have created alternate care sites generated them in a convention center environment where they had to tear them back down. So jumping into kind of the patients that we can see at an alternate care site in Tennessee, and this is pretty consistent with what we're seeing in other states as well. But we're looking at COVID-19 positive patients that have a low or moderate acuity disease. They're too sick to be home, but they require some level of support, including oxygen. And one thing I want to definitely caveat through all my discussions is none of these alternate care sites are open. We don't anticipate opening them anytime soon because there's additional surge things we need to do first, and I'll talk through that as well. So I didn't want to make any assumptions or if you think that any of these sites are open already. But to be able to get to an alternate care site, a patient does need to be seen at a hospital, acute care hospital in the state. And then we would only accept a transfer, like transfers happen every day in medical facilities from physician to physician. The facility is not designed to support complex medical conditions or interventions, so we definitely have inclusion and exclusion criteria that we would not take individuals with complex conditions. And if an individual does develop a more severe or critical illness that requires, high flow oxygen, ventilation, and things like that, they would be transferred back to a higher level of care that cannot be taken care of at an alternate care site with limited staffing and limited resources. The average length of stay, just based on some of the previous studies we've seen, is expected to look at about 4 days at an alternate care site, but that may vary. So we have to plan accordingly and be ready to manage that. So one of the big things that we look at when we're trying to determine how many extra beds do we need in our state is, what is our current hospital utilization? And so when we start looking at some of that data, these are some of the kind of inputs that we are constantly evaluating as far as hospitalizations on floor beds versus ICU beds, ventilated patients, and watching those trends over time. And it's really critical when we start looking at kind of the red on top of each of these areas, or 8 different areas that we have in the state. When we start getting into a surge bed capacity, so above what a typical facility would staff, that's when we start thinking about what is the next step for an alternate care site. And so these are all the different kind of calculations and things that we had to take into consideration to determine how many extra beds we needed and what kind of off-flow valve that we need in the terms of an alternate care site. So kind of jumping into construction, most of these are pictures for you, but so down in Memphis, we chose a facility that was the old Commercial Appeal newspaper building. And so they did just that. They generated newspapers. They have a two-floor high printing press in this facility. It's really cool seeing the history and everything that was there. But we brought the Army Corps of Engineers in to help renovate the facility. And so they basically tore the whole thing apart. So there was basically warehouse space on 4 different floors that was basically demolished and ripped apart. The amount of work these individuals did is heroic. Having a governor that is a contractor and our head of our Department of Military who's also in that field, they were just astounded by the speed and effectiveness these teams worked together on to build the site. And so this is kind of some of the finished products when we had the project finished. So we had 401 beds built out, or patient spaces, at this alternate care site in Memphis. And each of the spaces have oxygen, nurse call systems, reading lamps, place to plug your cell phone in, little USB, great Wi-Fi, place to watch your Netflix while you're sitting there needing oxygen. And then also we did actually develop 33 higher level of care beds that are in the bottom right-hand corner, kind of like isolation rooms in a hospital. They have the cool little ball on the wall up above, so you know when negative pressure, when you close that door, that it sucks in, and you know you've got a seal. We consider the whole building hot if we had patients in there, but that's just an extra level of protection. If we had an individual that we could not move to another acute care facility quickly because of the surge, and we had to stabilize them for a period of time, and they were on high flow oxygen, or if we did need to ventilate, we have a place to put them. It is not we would not accept someone like that, but we have the ability to stabilize a decompensating individual and then transfer as soon as possible. And so, again, a lot of the work with Army Corps of Engineers was the design phase. How do we put a nurse in the best position to take care of many patients, because we're going to have a limited ratio of nurse to patient and providers. So we needed to make sure that we set this up in an effective manner. So we have an on-site pharmacy, we've got nursing stations in the middle of the patient care areas, and so they're close to those individuals. And so the design and all these things, our minds were just kind of blown how they transformed that space into this building. And so again, there's 401 beds, 22 nursing stations at the facility. The fourth floor is like 4 football fields long if you had to go take care of a patient on one end. So that's why we would really talk about cohorting patients and managing it based on the surge that we're seeing. Again, oxygen for every patient, and we will have basic radiology and chest x-ray capability on site. The construction took a little over 30 days, and basically, if that would have been put into normal contracting terms and construction terms, it probably would have taken 16 to 18 months to complete. So this was 700 people working 24/7, so they got it done. And again, this Memphis site is unique because it's one of the only building conversions that is capable of being sustained for a period of 18 months because of the long-term lease that we have with the site. So our next unique model that we used in Tennessee, both are different than most other states, was kind of a hospital and a hospital model. So the Tennessee alternate care site at Nashville General Hospital, we've got 2 floors of their facility, 8th floor and 2nd floor, that we have converted into, again, COVID positive, low acuity space. And so again, on the 8th floor of Nashville General, it was basically storage space. There was no finished construction up there, and thus they had to kind of demo everything and get it prepared for a new look. And so a lot of work, again, went into building this space out, a lot of great capabilities. And again, they turned around an amazing space. So definitely a place I would want to hang out if I was sick. And so again, nurse call systems, it's got intercoms, it has great restrooms and different space for patients. It's light, it's has great access to the nursing stations and line of sight. And we definitely have privacy, and we've got triage areas and nursing stations built into the design. So again, 2 different floors, 8th floor and 2nd floor. A lot of attention to detail went into, say, like on the 8th floor, that pinkish or reddish area is kind of the hot zone, orange is the warm zone, blue is a kind of a cold area, making really clear we have designations for staff safety as they are transitioning in and out of PPE, where are the areas that they need to be concerned about. So 67 patients on 2 floors. There's 5 nursing stations. Again, all spaces have oxygen. What is really different about this site is kind of the wraparound services side. It allows us to completely subcontract this back to the hospital. So the hospital is taking care of basically every service they would on any one of their floors, but we have a contract with them to provide services to these patients in these areas. Again, it took U.S. Army Corps of Engineers a little over 25 days to take care of this. And again, it's unique because it's kind of a hospital within a hospital model. So on the staffing side, one of the things that we know we needed to do was not pull staff away from hospitals that are already dealing with surges and make a lot of enemies across the state. So that was our #1 plan. And so one of the things that we did early on was we contracted with University of Tennessee Health Sciences, and they helped identify Chief Executive Officer, Chief Medical Officer, and Chief Nursing Officer as a leadership team that we would subcontract with, partner with, plan with, exercise with, to prepare them to manage the day-to-day clinical needs of patients that would come to the site. So again, we worked to develop a staffing model based on some federal guidance, and worked on identifying the healthcare provider types that we would need. We executed a staffing contract with a contract company that has a footprint here in Tennessee, and so they're working with individuals. We have a Medical Reserve Corps volunteer system in the state, and we were able to push people to register on that site and then hand those names and those individuals over to the staffing company for preferred access to staffing availability. And so that is kind of in the process right now. We're actually using that staffing contract now to help support some of our remote testing sites too in the counties. We worked with our National Guard and State Guard folks also on the staffing side to help us with kind of the logistics operations to actually move the stuff into these sites and set them up. And then if we get to a trigger, so when we start monitoring again the surge in our facilities, and when we start breaking some of the planes as far as typical staffed beds and into surge beds, we have, or what we're predicting is about a 10-day window to activate. And during that time, we will be turning on various resources, including asking for additional federal staffing resources as well, which could be through the Uniform Public Health Service, through Health and Human Services. They also have some active duty teams through DOD that have been identified. So again, this is not a one-stop shop as far as staffing. We have to layer various different options on to be successful. And so we're really trying to cast a wide net to be able to be successful, to be able to staff the site effectively. And so our contract with our staffing company, again, we have the ability to allow other healthcare facilities that can't find staff to use this contract. They will have to pay for the staff themselves, but again, it is a kind of a redundant staffing contract if facilities in the state can't find staff. And so we built that into the contract that they can help hospitals, but they can also help our alternate care site to be able to staff up as needed. Wraparound services. So this is one of the biggest lifts in this whole process is all the contracts you need to be able to take care of patients. And it is immense. Again, Herculean efforts by our general services staff that sit with me over at TEMA, the number of contracts they had to generate, and the relationships we've had to build in this process, it's been a lot of work. So, contracts, more contracts, and even more contracts. So a lot of different areas. So bio-waste, food service. Food service is actually one of the hardest ones for us to wrangle. EMS, having them on site, having for Memphis, having a generator that's the size of a tractor trailer. Hotel available, ice machines, copiers, pest management, facility management, linens, oxygen. We basically have 2 silos that we had to install in Memphis to support the oxygen generation that we need for the site. Trash services, contracted pharmacy management, the medical teams, radiology, they'll have their actual x-ray equipment that they'll leave on site in the environment. The staffing contract, janitorial, alarm monitoring, a whole laundry list, and none of this is cheap. So managing all of these things, determining what we have to turn on now, what the amount of time needed to turn on when we actually are active versus kind of in a warm state, which is kind of where we're at right now. So there's a lot of moving parts to be able to make sure the site is well cared for. And then one of the final things is logistics and procurement. So this is actually one of our National Guardsmen at our warehouse that we have in Tennessee, managing some of the supplies that we have, but tons of things that we had to buy, supplies and equipment to outfit these sites so we can actually take care of patients, like bed monitors and IV pumps and beds themselves and all the supplies that you would need. So again, here's kind of a list of categories: beds, non-medical supplies, medical equipment, signage, material handling equipment. But other expenses that you don't really think about is site leases, and that can be quite expensive as well. The utilities at a building that's 4 stories and is quite expensive as well. And then the personnel to equip these sites and then actually put it into active state takes a big lift. So we had lots of effort, lots of hands, and I'm just very blessed to be working with the team that I am. So there's a lot of dedicated individuals that are trying to take care of Tennesseans to make sure we have plans in place. We don't want to activate this alternate care site at all, but we know that if we don't do the due diligence to prepare, that we're not doing what we should. So, so a lot of insurance policies in place here to be able to take care of populations if we have to continue to surge.
That's super interesting, Paul. So I think a few folks asked this question, and I have kind of the same one. Hopefully we don't have to utilize these sites. Are there any plans on what to do kind of when the leases are up, or if we knock on wood make it past kind of the pandemic or the acute phase of the pandemic?
That's a good question.
No, yeah.
So some of it is a little sensitive because a lot of these different projects are paid for using federal dollars. So 75-25 split, so federal government's paying for 75%, state pays 25%. So we really have to stay focused on the COVID mission and how we can take care of that, and then figure the rest out down the road. But if don't see this going away anytime soon.
Yeah, no, absolutely.
But yeah, just the keeping these sites warm and engaging the staff, and you know, it is a full-time job.
Yeah, no, I can imagine. Just listening to the contracts you had to sign gives me heartburn. As somebody who's had to navigate a few of them. I guess another question that I would ask is, you know, as you're acquiring some of this medical equipment, I know every other state and jurisdiction is probably also trying to acquire it. Did you have any issues getting the supplies that you needed?
Yeah, very much so.
Yeah.
So one of the challenges early on was, you know, we're like, okay, we need to buy some hospital beds.
Yeah.
None to be bought. And so we had to kind of a balance of what we were going to do. So we ended up basically finding a company that had a dorm-like bed.
Okay.
And so we ended up purchasing that because we could buy large quantities, and to try to make it more amenable to kind of a hospitalized patient, we found these 10-inch foam wedges that you can put under the mattress and lift the head of the bed, and you know, you can put multiples of those plus pillows, and they're actually quite comfortable. So that was one of the things that we really struggled with early on was beds. You know, the state's still trying to procure additional ventilators and things like that. We don't have a shortage at this time, but that was one of the things early on, in addition to all the PPE. But there definitely were some supplies, like we're going to have limited lab capacity at the site, so we have some, you know, iStat machines and things like that. So there was some lead time on those. There was some lead time on PAPRs and things like that as well. But yeah, we were able to kind of navigate. We had some great vendors with some medical supply folks that actually partnered with us to help us determine what we really needed and what we didn't need. And that was a huge lift early on.
Super interesting. Now, I was looking at those photos that you had of the 1918 flu pandemic, and I actually reread The Great Influenza, which, you know, is a book that kind of summarizes all that, and the I guess, similarities are really, really striking. I think
it is incredible.
There's actually a passage in the book that actually mentions using anti-malarial drug as, like, something that could possibly work against the flu, which is not too dissimilar to what we're looking at now. One of the questions that came up that I saw, we're having some difficulty displaying the questions, but one of the ones that I saw pop up was regarding the outreach that the Tennessee Department of Health is doing to address minorities and other disadvantaged populations. So I wish I had Dr. Kimberly Lamar here with us. So she is over our Office of Minority Health and Disparities Elimination at the Tennessee Department of Health, and her team has actually formed a COVID-19 health disparity task force to sort of address some of these issues that were identified early in the pandemic. So some of the things that I know her team has been working on have included working with faith-based groups and other community organizations to roll out testing, some targeted outreach and public service announcements to specific populations, you know, making sure that all of the documents and guidance that we have are translated into multiple languages, including Spanish and Arabic and other ones that we see, you know, somewhat commonly in Tennessee. Just trying to make sure that we are reaching everybody in you know, that in a language that they can understand, I think has been, you know, obviously one thing that we've tried to do. But I know that, you know, these efforts are ongoing and that there's probably much more out there that I'm failing to touch on today. So that actually might be a really good speaker for future provider calls, just to have Dr. Lamar walk through, I think, some of the things she's doing on her end, because it's truly been impressive, and I think she could probably speak to it better than I can. Another question that we received was regarding how to access the recent case rate thresholds that were referenced early in the call with regard to long-term nursing home or long-term care facility visitation. That actually is available on our website. So if you go to kind of the CDEP landing page for COVID-19, there's a tab that says Epi Curves. If you click on that, that actually will allow you to pull up the metrics that I mentioned, as well as kind of search by county. So that is available to the public, and it is updated daily, but we are trying to focus primarily on that 14-day average case rate, to avoid some of the confusion of, we know that the number of new cases varies significantly by date, and so looking at the average is probably a little bit more helpful from a operations perspective. We also got another question about, how are these visitation guidelines and limits going to be enforced in nursing homes? And so that's actually something that's handled by the Division of Health Licensure and Regulation, which is separate from my team, but that's the group that does licensing of these sites and also does the annual inspection for them. And so I would have to defer that question to them, but I know that it's something that they're monitoring to make sure that it's done as safely as possible. I'll also add that my team, which is the Healthcare Associated Infections team, is trying to work with as many facilities as possible that either have experienced COVID-19 outbreaks or are just trying to prepare for COVID-19 outbreaks. Obviously we've done a lot of focus for long-term care facilities, but we're also available to help with outpatient practices and acute care hospitals and any other healthcare settings. And if you would like to reach one of our infection preventionists, that email address is hai.health@tn.gov. And it looks like we've got a couple of other questions about the alternate care sites, so I will let Dr.
So question 3. What are the triggers to open the sites? Are they geographically based? And how would you decide to open them and which one? So again, all pandemics are local. So, that's why we kind of have the state broken up into kind of 8 different EMS or healthcare coalition regions, which is kind of the standard flow of patients to healthcare facilities. And we monitor both the bed availability and then all the epi data as far as the percent positivity on a daily basis, as far as cases, and the kind of the speed of growth of that increase in cases as well. So all of those things come into factor, but we are actually looking at some different triggers as far as what their normal staffed beds are. Every hospital has worked with us and the Tennessee Hospital Association to identify their surge capacity that they have that they can scale up to. And so we would definitely start having conversations once we move into that surge capacity. But we are also very cognizant that one of the triggers to open these sites may be very political. So it is a balance of, again, science and politics to be able to open these sites. And so there is no one-word answer that I can give you for that. But it would be geographically based. Just because, say, we opened the site in Memphis because there was no capacity does not mean we would have to open up Nashville. It would all be based on the data that we are seeing locally and how the healthcare system is doing. Okay. Will there be any uses for the ACS when things go back to normal? Homeless, mental health. Again, I think we kind of covered that. We can't really go into second uses for alternate care sites because of the federal funding that was used. We do not want to have to pay 100% of the construction costs. And so for a period of time during this pandemic, they have a purpose-built mission, and that's what we are addressing. The alternate care sites, they are leased by the state. So the state operates that facility both in Memphis and the floors in Nashville. We contract back the services to the Nashville General Hospital to provide those services to the state. But the state is the one that makes decisions as far as opening, closing, and kind of escalation of different things. The alternate care sites do not have a visiting space, but we have accounted for that in kind of building in a process so we could allow for things like FaceTime or other types of video call capabilities to connect family members and loved ones together that they're at the site. We do not want to put anyone at risk, including the media. We're not going to allow the media in. They've got to take their pictures during the construction phase. They don't get to go in when there's sick individuals in the site. So same kind of process that we've dealt with other healthcare facilities through this pandemic and limiting visitor access.
Let's see. I think we've got all of the questions that have been asked so far. We'll leave the line open for a few more minutes just to see if anything else comes in, but super interesting talk. I had no idea how much work went into these. Somebody asked me early in the pandemic if there's a subject matter expert on who could write down everything that you would need in a hospital, and I kind of cowered.
Yeah, well, at the beginning of this, it wasn't me either, but I was up for the challenge, and we had a great team.
Yeah,
so,
yeah, that's super.
The federal partners were great throughout the whole process.
Awesome.
They sat there right with us at TEMA, building along every day. We got daily updates on construction progress, and we continue to have almost daily calls with the different teams to support the continued implementation. One of the cool things too, we just a couple weeks ago, we did an actual exercise where we moved patients through the Memphis site. So we actually had someone get off an ambulance, be taken to the triage area there in the EMS bay in the warehouse at the Memphis site, and they had to do the normal workup they would normally do. We had a patient medical record that came with them, so they had to do their normal assessment. We had a simulation cell that tried to kind of trick the staff and give them different inputs to see how they would react. And so we moved patients all the way through up to care on the floors, to different instances they may have on a floor, to de-escalation of a upset patient, to a decompensation patient that had to move to one of those higher acuity beds, to discharge. And so that was a great experience, really looking at all the different things that we had been working on. Of course, it enumerated tons of things we continue to work on, but that's why this process is kind of never going to be an ending. It's always going to be a refining quality improvement process.
And what types, this is just another, I guess, random question, but in terms of medical records, is it all kind of paper-based, or is there?
So we do have a paper-based medical record that we've generated. We're also in the planning phase of using our existing emergency preparedness patient tracking system for patient census on registration. And then we will, again, kind of track census. One of the big things, of course, whenever you start a new initiative, leadership will want information. And so we're proactively trying to identify what in the emergency management space we call our EEIs, or essential elements of information. What are those discrete data points that give people situational awareness? So we're developing processes to be able to make it easy for the medical staff there to be able to collect those things, so we can inform leadership, create pretty visualizations and dashboards and those kind of things, so we can be proactive with that.
We received a question about initiatives that the Tennessee Department of Health are using to promote face coverings and hand hygiene. So I know there have been a lot of social media posts about face coverings. I do believe there are discussions to sort of ramp that up as more things open. And in terms of hand hygiene, I think there's also been some similar messaging around that. But I think we are far from done pushing those messages out. So more to come on that.
Yeah, it's the Tennessee Strong initiative is they're getting a bunch of different business partners involved.
I saw
and so we had the first 30 businesses that got into the game, which would be like big universities and sports teams, and then there's going to be the big 50 is their next goal, and then a push to 100 different businesses across the state. So the state is actively, the Economic Recovery Group is actively seeking partnerships with different businesses to create some branded masks to get some ownership and some invested kind of community pride in wearing some of the masks. So some local county governments and city governments are generating their own as well.
And I will say, just as somebody who is not a big fan of makeup, that wearing the mask is a great way to avoid having to put more stuff on your face. A built-in bonus there, and also it really appeals to the infectious diseases physician in me.
There you go.
To limit disease spread. So I think if early in the pandemic, if you really didn't find a mask comfortable, there's so many options out there, and hopefully will be so many more branded options from Tennessee that you can use. So really, no excuse to not wear one. It really is a great way to, not only protect others, but also probably provide yourself with some protection against COVID-19. Also, I guess another thing, just since I am infectious diseases, I'll just kind of put a plug out there that things like alcohol-based hand rubs are becoming more and more available and easier to find out there. Early in the pandemic, I was going to local distilleries and purchasing hand sanitizer. I think, fortunately, we're starting to see more and more of that in stores. There were some public announcements this week from FDA that advised against the use of specific ones that might contain methanol, because that can be toxic, but there are, plenty of others out there that are safe and that I think are well worth the purchase to use.
I guess one other thing on the infectious disease front is the ability to leverage the Battelle decontamination system that we have in the state. So we do have a federally provided free system to have healthcare facilities, physicians' offices, clinics, dentist offices be able to sign up with the Battelle company, B-A-T-T-E-L-L-E, and we can make sure that information is available. But it allows you to register as a provider in Tennessee, and they come in for free, use FedEx, and pick up your N95s that need to be decontaminated. They have a hydrogen peroxide system. It's 7 huge, basically tractor-trailer type containers that they have this deployed in Jackson, Tennessee. And it allows those N95s to be, again, decontaminated and brought right back to you. And so when we're in a phase of potentially increasing cases, potential, again, concern about PPE utilization, that is something that everyone at TEMA and here at Health are pushing as a resource that is free. Again, free, you don't hear that a lot.
I know.
For healthcare providers to be able to get their N95s cleaned in a FDA-approved, validated fashion that you can trust, and be able to get those masks back to you, especially when we have limited resources and are worried about not having things that protect our healthcare workers.
And that's a really good point. There's some good data out there showing that, hydrogen peroxide decontamination is really effective and does not affect the efficacy of N95 respirators. I think probably the important thing is to just make sure that you visually inspect those before you use them again, but again, perfectly safe to reuse them several times as long as you're decontaminating. And I think Battelle can provide some really good information and instructions on how to do that.
And one thing that does kind of negate a mask being decontaminated is if there are makeup or type things that they can visibly see in the mask. So what we're seeing, I think we've had close to about 10,000 masks go through the process so far. We have a little over 450 different specific sites registered currently, but about 25% of the masks get disposed of because of visible soiling, and they will not clean a mask that has that.
That is a good point, and also something that I'll emphasize that is kind of a good mantra. If it's dirty, you can't disinfect it. So if you have something that has visible soilage or visible body fluids or anything like that, please clean it with soap and water first before you use the disinfectant. I think that's something that we're seeing in healthcare settings a lot as people, obviously are trying to do the right thing and clean more regularly, but before you add a disinfectant to any kind of surface, you need to make sure that it's clean. And it sounds like that's also the case with N95 masks.
Yeah.
We've got a few more minutes. I'm not seeing any other questions roll in. But thank you all for, having us. And Dr. Fiskus will be back in 2 weeks. Again, no call next week. We'll resume things on July 10th. If you are a healthcare facility or provider and need to request PPE, there's a document on our website for using Survey 123, which is the survey for that the Tennessee Emergency Management Agency uses to distribute PPE, and I will kind of go ahead and say that our availability of PPE is limited, just like everywhere else at this point. And so if we're not able to fulfill every request, it's not because we don't want to. It's just because that we are limited by the same suppliers as other folks. But trying to push out as much of that as possible. And with that, I guess we will sign off. I hope everybody has a relaxing weekend. Make sure to wear your masks and do that hand hygiene and stay distanced. Thanks, everyone.